Hi there, this is Nazul, and I'll be presenting bowel obstruction, which is a lower gastrointestinal disorder. During this lecture, we'll be looking at the classification of bowel obstruction, and there are two classifications: mechanical bowel obstruction and a non-mechanical, which can also be referred to as a functional bowel obstruction. When we're presenting or looking at these two types of bowel obstruction, we'll look at it from the etiological risk factors, the pathophysiology that's involved, and a clinical manifestation, how they differ between these two types of bowel obstruction. So before we get into the actual content of bowel obstruction or intestinal obstruction, I think it's important that we look at how does food propel or travel through the GI tract. So once food is consumed and it's broken down by gastric juices and other intestinal juices and chemicals, as we try to break down food in their smallest component to obtain nutrients from it, the food is then made into a bolus, and that bolus has to get through the GI tract. One process by which food gets through the GI tract is by peristalsis. And really what peristalsis involved is the longitudinal, circular, and diagonal muscles that is in the GI tract will contract. And this is where you're seeing the contraction right here. And that contraction allows for a kind of sequential or a wave-like motion that will then push the food forward through the GI tract. There's also a different process involved at the same time called segmentation. And segmentation mostly involves the longitudinal and circular muscles in the small intestine where they kind of squeeze food back and forth along the intestinal wall, all in an attempt to move food along and also allow for nutrients and chemicals to be absorbed from the small intestine. So that brings us now to discussing what is an intestinal obstruction. Without making classification, that is whether it's mechanical and or non-mechanical, just as a broad discussion, intestinal obstruction really involves either a partial or a complete obstruction in the intestine that prevents contents or intestinal contents from getting through the GI tract. Most often where it occurs is in the small intestine, but being mindful that bowel obstruction can also occur in the large intestine. Obviously, because of the narrowing of the tube, that we often would see obstructions happening mostly in the small intestine. So it's not uncommon to see diagnoses of SBO, which is really small bowel obstructions. So when we look at bowel obstruction as a broad category, that bowel obstruction can then be split or classified into a mechanical obstruction and or a non-mechanical or functional obstruction. Bowel obstructions are classified based on the cause. So mechanical obstruction, the causes are different from those of non-mechanical or functional obstruction. When we look at mechanical obstruction, there is physically something that is obstructing or causing an occlusion. So an obstruction and or an occlusion in the lumen of the GI tract. Therefore, once there is something physically there in the lumen, it does not allow contents of the GI tract to get through. Whereas with a non-mechanical or functional obstruction, there is no physical obstruction or physical occlusion within the lumen of the GI tract, but rather what is happening with the non-mechanical or functional obstruction, there is a loss of peristalsis. And remember earlier we talked about the importance of peristalsis and segmentation in moving contents forward within the GI tract. So loss of peristalsis therefore means that there's going to be stasis of the gastrointestinal content trying to get through the GI tract, leading to an obstruction within the gastrointestinal tract. So looking at bowel obstruction, when we look at the two classification, which is mechanical obstructions and non-mechanical or functional bowel obstruction, the reason that these are categorized and or classified this way is based on the cause. So the causes of mechanical obstruction would look differently than that of functional obstruction. Now with functional obstruction or non-mechanical, the most common type is referred to as paralytic ileus. When you see the word ileus, ileus simply means gut. So when we use the word ileus, this means that gut, and therefore what this simply means that a paralyzed gut. Now you'll also see that there's an alternative term that can be used instead of paralytic, which is we could refer to it as adynamic ileus. Pretty much have the same meaning, where that gut or the ileus is lacking peristalsis, resulting in a bowel obstruction. So causes of mechanical obstruction includes tumors, adhesions, hernias, volvulus, or a telescoping of the bowel. And this will all be discussed on the next slide. So something is physically present that is causing the obstruction or occlusion within the GI tract. So it could be a tumor that's present there, it could be an adhesion that's there, or the patient has a hernia and or a volvulus, or the bowel is telescoping itself, that is causing that physical obstruction to occur. Now remember, with an adynamic ileus or non-mechanical, there is no physical obstruction within the GI tract, but rather there's a loss of peristalsis, not allowing for the contents to move through. So when you think about what causes a bowel to become paralytic or to become adynamic, think about inflammation and the release of chemical mediators that can potentially, during that inflammatory process, stop or put a halt to peristalsis. So things like pancreatitis, peritonitis, any sort of infection within the abdominal cavity, hypokalemia can do it, post-surgery as a result of anesthesia, etc. There's medications that can also cause this to occur. So there's many examples of things that can result in a functional bowel obstruction. But again, just to recap, the classification, whether a patient has a mechanical bowel obstruction versus a functional or non-mechanical, is primarily dependent upon the cause. So looking at the causes of mechanical obstruction, I first off would like to say these images were adopted or taken from Medical Surgical Nursing in Canada, 4th edition by Lewis et al. And so when we look at the causes, one of the first one we look at is A, which is adhesion. So this A diagram is looking at an adhesion. And so when you ask yourself what is an adhesion really is a band of scar tissue that is kind of attaching or banding two loops of bowel together. So a band of scar tissue holding together two loops of bowels. And so if hold together the loops of bowel, what that means is contents cannot get through the GI tract. So as content is trying to make its way through the GI tract, there is a physical obstruction at the point of where the adhesion is. B, which is looking right over here, this is a hernia. And so this is a male patient, and often what it is really, a hernia is where the intestine pretty much gets through the inguinal canal and it's kind of stuck there, again causing an obstruction, because as the content of the GI tract is trying to get through, then it's blocked or it's kind of cut off where it's trapped in that inguinal canal. Now women can also have hernias. Often it's abdominal hernia, and usually after a pregnancy where the abdominal muscle becomes weak, or if you've had multiple abdominal surgeries where again the abdominal muscles become weak, the gut can then kind of slip through within the muscle and get trapped, again resulting in what we refer to as an abdominal hernia. C is looking at, and that's right over here, this is called intussusception, or what's often referred to as telescoping of the bowel. So in the previous slide, we talked about telescoping of the bowel, and what it really means is one portion of the bowel slips into, or it kind of folds itself, just exactly how a telescope slides into itself. But if you think about it, now the content of the GI tract is trying to get through, it's hitting a physical obstruction because of the telescoping. Intussusception, or telescoping of the bowel, is very, very common in children, more so than your adult patients. So babies are often subjected to telescoping of the bowels, and so their presentation, how they present clinically, is they would come in with projectile vomiting, they're crying, they're inconsolable, often the legs are pulled up, and they're just in excruciating pain. So intussusception is also referred to as telescoping. F is showing you what a neoplasm is. So a neoplasm, or a tumor, will then also cause an obstruction or an occlusion within the lumen of that GI tract, not allowing content to get through. And then lastly, G, this is called a volvulus. And now the reason or the cause for a volvulus is often idiopathic. So they're not exactly sure what causes a volvulus to occur. And really what a volvulus is, it's the twisting of the gut, where the gut kind of like band itself in a knot for idiopathic reasons. But again, as the content is trying to get through to the GI tract, once that knot is there, then you can't put the content through, again leading to a mechanical bowel obstruction. So in our previous slides, we looked at the causes for mechanical obstruction. Now looking at the second classification for bowel obstruction, non-mechanical or functional obstruction, remember in the previous slides we mentioned that it involves a loss of peristalsis. So things that might cause a loss of peristalsis is some sort of neuromuscular or vascular disorder. And with non-mechanical or functional obstruction, there is a halt in peristalsis where it's non-existent, and therefore the contents within the GI tract cannot move forward. There is no physical obstruction within functional obstruction. It just means that the ileus, or the gut, becomes paralyzed or adynamic. And the most common type of non-mechanical or functional obstruction is something referred to as paralytic ileus. So there are many causes to functional obstruction, and one of those things is post-op. So often this is referred to as post-operative ileus, where you'll see a decline or an arrest in intestinal motility post-operation. There are many risk factors that can cause this. So some of the things that can result in a patient ending up with functional obstruction post-op could be age, could be a big reason in why they're at risk. Electrical imbalances, electrolytes imbalances. So when we look at some of the electrolytes that can become imbalanced during surgery, potassium, sodium, those are all things. Calcium as well can also become abnormal. Surgical factors, so start to think about medications that are used. So opioid medications, attaching to Mu and kappa receptors in the intestine, slowing down intestinal motility. Also, we could have some contamination in the process when they're doing abdominal surgery could occur. So there are a number of reasons why. Initial stages of a spinal cord injury. With spinal cord injury, always remember that within the GI tract, we do have the nervous system, so often referred to as the enteric nervous system that innervates the GI tract. And so what it does is it receives the signal, and that's how it's communicated to cause the release of gastrointestinal juices, etc. So in that initial stage of your spinal cord injury, that message from the enteric nervous system becomes lost, and therefore what we are going to see is a halt in peristalsis to try to squeeze or have that sequential movement to move things along. Pancreatitis, peritonitis, or an infection in the abdominal cavity all are causing a release of many chemical mediators that can cause cessation or a halt in intestinal motility. Hypokalemia, a very, very important electrolyte that helps with contraction of muscles. And so if there is hypokalemia, and don't lose sight of your hypocalcemia, so a drop also in calcium ions, then that could also result in a decrease in intestinal motility. And in burns, burns is a big one where we see fluid shifting in burns. Often fluid shifts out of the intravascular compartment into interstitial and third space, reducing that intravascular volume, which means that we're going to see hypoperfusion. Remember the gut, when your patient is hypovolemic or they have a low blood pressure, the gut is not really considered an essential organ. So once that fluid shifting is occur, you're going to see hypoperfusion to the gut. And so because of the hypoperfusion to the gut, enough blood supply, oxygen and nutrients is not getting to the gut, and therefore that could result in an adynamic ileus because we're losing that peristalsis to move the contents along. So in this slide, we're going to look at the pathophysiology of an intestinal obstruction. So when we look at the intestinal obstruction, this could be as a result of a mechanical and or a non-mechanical obstruction. But often it's just easy to look at the mechanical obstruction because we know there's something physically there. So in this case, we're going to kind of insert an obstruction point right here, and we're going to say that's our point of obstruction. So it could be a tumor, it could be an adhesion, a volvulus, intussusception, or something that's causing the obstruction to occur. Now this patient has just consumed food, and so that bolus of food is making its way down, and then it hits the point of the obstruction. Now remember, we talked about the enteric nervous system that not only promotes the peristalsis or allow for peristalsis to occur, but it's also going to encourage gastric juices, all those things to be released to try to break down this bolus of food. But once the food has hit that obstruction point, what you're now going to see with your patient with an intestinal obstruction, there's going to be an accumulation of gases, and so that gas that is being accumulated there could be as a result of the patient swallowing air just from talking and all those activities, or it could be from intestinal bacterial metabolism that's occurring. So we're going to see accumulation of gases, gastric juices, and this is all accumulating in the area proximal to the blockage. So just where the area of blockage is, just proximal, we're going to see the accumulation of this gas. So what does this mean for the patient? So if we were to look at the intestinal area, we're going to say this is where the tumor is, and that bolus of food is just behind here, trying to make its way through. But now what's starting to occur is we're going to see fluid. So this is our fluid is accumulating here, air is accumulating, and that's all accumulating in the area that's proximal to the obstruction. What that's going to then result is what you're going to see physically in the patient as abdominal distension. So it's not uncommon that one of the clinical manifestations of an abdominal intestinal obstruction to be abdominal distension. Now, as that fluid and gases are accumulating in this area, this is further sending a signal to or via the enteric nervous system to say, come on, make stronger contractions in the intestine in an attempt to try to move the intestinal contents along. So what you're now going to see is strong contractions. So remember, we're referring here to a mechanical obstruction. So we're going to see strong contractions of the proximal intestine. And those contractions are again occurring because it's trying to push the content along. So if we kind of draw the gut again, what we're going to see is if that bolus of food is right here that we're trying to move along, but remember we do have our obstruction right here where I'm going to see strong contractions is occurring right proximal to this area, trying to move that bolus of food along. Unfortunately, because we have an obstruction there, even though we're seeing the strong contractions there, the food cannot be pushed along any further. So because of that gas, the increase in fluid, what we're now going to see is increased pressure in the intestinal lumen. So inside of the intestine, we're going to see increase in the pressure. And so we wonder what is the implication for that increase in pressure. And one of the implication is we're going to see increase in intestinal secretions. So now we have more fluid accumulating in the area proximal to that blockage. And the more we have intestinal secretions accumulating there, we're going to start to see the veins within the intestinal wall is going to start to compress. So this is going to lead to compression of the intestinal veins. And as the intestinal veins are compressing, what we're now going to see is fluid shifting is going to occur. So this will cause not only the veins, but also blood supply to the intestinal wall is being compressed. And what this is going to lead to is fluid shifting into the peritoneal cavity. And this is going to further cause and also into the walls of the intestine, leading to edema of the intestinal wall. So because of this fluid shift, and I also don't want to lose sight, is once you have that increase in the pressure in the lumen, the obstruction, the increase in the intestinal secretion, all of this is now going to also lead to vomiting. So remember the GI tract has two openings, the mouth and the anus. So if we have an obstruction, where you've seen our point of obstruction here, if the content cannot go through the GI tract and out through the rectum, then that's going to back its way up. So now it's going to back its way up all the way out. And what we're going to see is emesis in the patient, okay, or vomiting. So that's also, so abdominal distension, I'm going to kind of put these, circle them in purple. So an abdominal distension is one of the manifestations. So our manifestations are going to be in these little purple boxes that we're going to see. These are going to be our clinical manifestation that we're seeing in the patient with the bowel obstruction. Vomiting, also not uncommon to see in patients with a bowel obstruction. So once there is edema, because of the persistent vomiting that we're seeing, the fluid shifting, and the edema within the intestinal wall, What these things are then resulting in, overall, they're resulting in hypovolemia in your patient. So this is all going to result in hypovolemia in the patient or loss of intravascular volume. Now, because we're losing that intravascular volume, this is then going to lead to hypoperfusion of the intestinal tract. So now we have less blood going to the intestinal tract. So this is going to lead to hypoperfusion of the gut. And as there is going to be less blood going to the gut, makes sense, this is now going to result in ischemia and potentially necrosis of the gut. So now the gut is losing blood supply, the arterial blood supply has been diminished, and that's now going to lead to necrosis or ischemia within the intestinal tract. As the gut becomes ischemic and necrotic, it means that we're now going to see cessation of peristalsis. So if you start to think now, this is almost kind of heading into the gut becoming adynamic, or the gut is now presenting like a functional obstruction. And as that starts to occur, what we're now going to see is that necrosis in the gut and with the decreased peristalsis is now going to cause perforation of the bowel. So this can then lead to perforation of the gut. And so a perforation simply means is a hole in the gut, and this can cause contents within the GI tract, such as intestinal bacteria, endotoxins, all that stuff, to leak into the peritoneal cavity, resulting in what's called peritonitis. Now, I don't want you to walk away thinking that peritonitis will always occur in a patient that has a bowel obstruction. No, peritonitis is a complication of someone that is experiencing a bowel obstruction. So that's like late stage. One other thing that I want to point out with a mechanical bowel obstruction that could be a clinical manifestation is in the area when we see a strong contraction of the intestinal wall to try the movement, to move the content along. What this will be heard as when you auscultate the abdomen is you're going to hear hyperactive bowel sounds. So this will result in hyperactive bowel sounds in the GI tract. Okay? And again, this is another clinical manifestation. So in early bowel obstruction, we're going to hear hyperactive bowel sounds proximal to where the blockage is. Abdominal distension is common. Vomiting is common. Now, if the gut becomes perforated and or the patient end up with peritonitis, at that stage of the game, that will lead to absent bowel sound. So absent bowel sounds will occur in the later stages of a mechanical bowel obstruction. So what this really captures is the pathophysiology that's involved in a mechanical bowel obstruction, just kind of giving you the idea of how the disease process is going to be manifested. So just looking back at this diagram, I just thought it was interesting to look at it from the perspective of how fluid and air is accumulated in the proximal aspect from where the obstruction is. So this is showing you kind of what I drew before, but now this is kind of showing you where that obstruction is, and then the fluid that accumulates, and then air that accumulates, all of which is going to lead to proximal bowel dilatation, causing abdominal distension in the patient. So completing a quick compare and contrast between mechanical and non-mechanical or functional obstruction, the very first thing is looking at the cause. With mechanical obstruction, there is a mechanical obstruction or a physical obstruction that is preventing contents of the GI tract to flow through the lumen. And if we quickly try to recall what are some of the things that do cause a mechanical obstruction, it's things like tumors, volvulus, which is a twisting of a bowel, intussusception, which is the same as telescoping of the bowel, hernias, etc. Whereas in non-mechanical or functional obstruction, with the most common type being paralytic ileus, there is no mechanical obstruction within the lumen, but rather there's a loss of peristalsis, or where we have cessation of peristalsis. And that could occur for a number of reasons, so things like pancreatitis, peritonitis, hypokalemia, or any other electrolyte imbalance, even such as hypocalcemia, can result in the loss of peristalsis. Also looking at the type of discomfort the patient will endure once they have a mechanical bowel obstruction, it's more of a colicky pain. And if you try to think back at why it is colicky, that has to do with the increase in peristalsis proximal to where the obstruction is. Whereas in non-mechanical or functional obstruction, because of the loss of peristalsis, the patient is going to experience more of a constant, steady discomfort. Hyperactive bowel sounds. So in the early stage of mechanical obstruction, there's hyperactive bowel sounds. And where exactly is that hyperactive bowel sounds? And if you recall, it's located in the area proximal to where the obstruction is. And the reason why it's located there is because it's trying to move along that obstruction through to the GI tract and trying to move things along. Now remember, and this is early mechanical obstruction. As the mechanical obstruction progresses, there is a chance, if it is not treated, there's a chance that we can have necrosis, ischemia and necrosis to the gut, which will then cause that gut to perforate, pretty much putting the patient into a functional or adynamic ileus. With the non-mechanical or functional bowel obstruction, there is decreased and or absent bowel sounds because there is no peristalsis and nothing is moving through the GI tract. So looking at the treatment that is involved for intestinal obstruction, the primary treatment is first inserting an NG tube or a nasogastric tube. And the reason for inserting that is for bowel decompression. And what we mean by bowel decompression is we want to remove, so if you recall, once there is an obstruction, there is going to be excess gas and gastric juices and other sort of GI secretions that is accumulating proximal to where the obstruction is. So by inserting an NG tube and attaching that NG tube to low intermittent suctioning, we're able to remove that excess gas and secretion to decrease bowel distension in the client and also to decrease the risk of vomiting, because you know there is a high risk of vomiting, and once the patients vomit, along with the fluid shifting in the GI tract, they're at risk for hypovolemia. So one of the primary treatment when you have a patient with an intestinal obstruction is the insertion of an NG tube. Now surgery is also a second option. So if there is no resolution with an NG tube insertion, then the patient will be taken for a surgery. This is just to give you a recall of the amount of fluid and or air that end up accumulating proximal to that obstruction and can cause abdominal distension and increasing pain, nausea, and vomiting in a patient with a bowel obstruction. Here again, this is kind of just showing you, and this was taken from the JAMA network, and this just again shows you that when someone has a small bowel obstruction, then it's normal to insert an NG tube, and mostly what it is to remove the fluid from the stomach or from the GI tract so that we're decompressing the bowel, and again try to help to reduce the dilatation that is happening in the small bowel. Also very important, which is often covered in theory, is during your NG tube insertion, the patient will always have IV fluid replacement for the nasogastric content that is being removed or drained per shift. Now, just for simple practice purposes, 2 questions were included to help sort of solidify the content. And the first question is, which of the following most likely result in a mechanical obstruction? Select all that applies. Adhesions, pancreatitis, occlusion to a mesenteric artery, a volvulus, peritonitis, and hernia. So if you recall back from the beginning or the earlier slides of things that can cause, so the key words in this question is mechanical obstruction. So something is physically obstructing the lumen of the abdomen. So if adhesions, yes, because they are a band of scar tissue that attaches 2 loops of bowels together, preventing the flow of content through the bowel. Pancreatitis, inflammation of the pancreas, wouldn't result in a mechanical obstruction, but rather a functional and or a non-mechanical obstruction. Occlusion of a mesenteric artery. So the mesenteric artery supplies the GI tract or the gut with oxygenated blood. If there is an occlusion at the mesenteric artery, that's going to prevent oxygenating blood to get to the GI tract, which can subsequently lead to ischemia, necrosis of the gut, and ultimately a functional or non-mechanical obstruction of the abdomen. So C is not an option. Volvulus, which is a twisting of the bowel, is allowing for a mechanical obstruction to occur. Peritonitis, again, inflammation within the peritoneal cavity will result in a non-mechanical obstruction or a functional obstruction. And lastly, a hernia, where the bowels are trapped either in the inguinal canal or the abdominal muscle, will definitely lead to a mechanical obstruction. So when it says select all that applies, your answers would include A, D, and F. Which of the following is a characteristic sign of mechanical obstruction? Abdominal distension, colicky abdominal pain, steady, diffuse abdominal pain, and absent bowel sounds. And so when you're looking for the key words in the stem, so which of the following is a characteristic sign of mechanical obstruction? Abdominal distension. Well, we could potentially have abdominal distension with any bowel obstruction. So regardless if it is a functional and or a mechanical obstruction, so A would not be the best choice in this matter. Steady diffuse abdominal pain is mostly seen with functional and or non-mechanical intestinal obstruction. And bowel sounds being absent, again, is seen with a functional obstruction. Colicky abdominal pain is most characteristic of a mechanical obstruction. So in this case, your answer will be B, as in Bob.